Thank you very much. Thank you very much, Stacy. Yes, I am Lisa Larson-Bunnell. I see a lot of familiar faces here, so I think I have spoken to a lot of you in the past. And how many of you were not here in 2015, the last time I spoke about EMTALA live to your group? Okay, just a couple of people. Well, this is going to be really boring for 95% of you. The good thing about EMTALA is that it doesn't change very much. We haven't had a major revision of the EMTALA regulations for several years, but we do have some enforcement cases and some civil lawsuits that do help to add some, what I would call color, to the interpretation of EMTALA standards. So we are going to talk a lot about enforcement actions. Before I even get into EMTALA though, I want to talk just a moment about interpreter services. 2 years ago when I came, we had a whole presentation about interpreter services, and we were really trying to build the sense of urgency around the need for having appropriate interpreter services in order to maintain patient safety. We had our recent Joint Commission visit, and interpreter services was one opportunity for improvement that they identified. Now, good news is this did not come from the emergency department, so congratulations. Woo! However, we did have an employee in another department, when asked by the Joint Commission surveyor, basically stated that we use family members to interpret all the time. And it's not that that is an inaccurate statement, but it was really only part of what they really meant to say or intended to say, or essentially what they really intended and what they documented on this case was that they offered a professional interpreter. The patient said, no, I don't want a professional interpreter, and asked for their family member to interpret. We do honor those wishes, and that's okay, but I do want to make sure that you all understand the distinction between a patient requesting that we have a family member interpret and us having the obligation to offer professional interpreter services. The other thing that I like to talk about is the fact that we can tell a little white lie to our patients to ensure their safety. If you ever feel like the family member that they are wanting to interpret is either not capable of providing an appropriate interpretation or is not acting in the patient's best interest, I think it's totally appropriate for us to say, you know, it's against hospital policy for us to have family members interpret, even though it's not exactly true. Some examples might be, let's say that you had a patient come with their 10-year-old son, okay, and they say, oh, he speaks very good English. Probably not the best situation for an interpreter. That is the situation where I would say, you know, really we need to bring in an interpreter, and you need to assert that on behalf of that patient's safety. Another situation might be if you are presented with a patient who you suspect of being the victim of domestic violence, and it is their domestic partner that is there with them and that they are requesting to serve as the interpreter. That's probably, again, a time where we need to say, sorry, hospital policy doesn't permit me to use this family member. Little white lie to ensure patient safety. Is everybody clear on that? Any questions about interpreter services? Yes?
I thought the family member had to be over 18. Is that incorrect?
Well, that's my preference. I don't think that we have that in the policy. The policy just talks about the family member. I think that the policy envisions that it would be a family member that is at least of age, but I know that that's not always the reality of what we're presented. So I just wanted to cover that. Okay, EMTALA. So who can tell me why we have EMTALA? And if you were here in 2015, please speak up. Or 2016 when Linda did her training. I mean,
Linda's already Would you say they lose their baby because somebody said, we don't take your insurance here, you need to drive it down the road, and in between they died or something else?
yeah, so what I'm hearing you saying is that there was a case where somebody lost their baby because they were told by one hospital that we don't take your insurance and you need to go to another hospital, and in the process of that transfer, the baby died. I am not sure if that is the exact case that may have happened in the 80s, but what was going on is that there were a lot of cases like that had those same kind of tones and undercurrents. Some specific ones that I remember, yes, related to the baby one, I remember a case, and by remember I researched, and I remember in my research a case where a woman presented in clear active labor and delivered in the parking lot of the hospital after the hospital determined that she had no ability to pay. Another situation, literally patients or people presenting to the emergency department with knives in their backs because they were assaulted, and the emergency department doing what was then called a billfold biopsy and saying you can't be treated here. So it wasn't that this was happening in every hospital, and it wasn't even that this was happening in every state. What was happening nationwide, though, is we had a patchwork of laws that were in place that essentially did what EMTALA eventually ended up doing, but it didn't apply to all hospitals. And that sort of is troublesome for the federal government because they're the ones that are giving hospitals, in many cases, a majority of the revenue that they're receiving is federal dollars. So Congress enacted EMTALA. It is known as the Anti-Dumping Law. Officially, it is called the Emergency Medical Treatment and Active Labor Act. And EMTALA is there to serve as a baseline for our responsibilities to patients who present to the emergency department seeking emergency treatment. So this slide right here, called EMTALA Obligations, is everything you need to know about EMTALA. This is it. It's all right here. So EMTALA first applies to all individuals who come to the emergency department. It says that they shall receive a medical screening exam by qualified medical personnel and that they will be provided with stabilizing treatment when necessary, and when necessary will be provided an appropriate transfer. So that's really simple, right? It makes a lot of sense. Those aren't really legal words. But the trouble with EMTALA and trying to interpret EMTALA is when you're looking at this slide, it's a little hard to see. But the highlighted phrases actually have specific legal meanings under the rules, and it's important that you understand what those specific meanings are. So we're going to go step by step through this. First one, EMTALA is triggered when somebody comes to the emergency department. Now, when we think of the phrase comes to the emergency department, I think our mind automatically goes to that vision of the person walking through the revolving doors and saying, hey, I want emergency care, right? It could also be maybe that they were transported by ambulance to the emergency department, but either way, they're getting to the emergency department. And that is absolutely true. Our EMTALA obligations are triggered then, but they are also triggered when the patient presents on hospital property and makes a request, or a request is made for them for emergency medical treatment. Now, that request can be implied. So if somebody is on hospital property and they are found unconscious, we can imply that they are requesting emergency medical treatment. They don't have to request it themselves, and there doesn't even have to be somebody there to explicitly request it. Hospital property in this case is really hospital property. This is kind of our Clay Edwards Drive circle and all of the buildings around it. The only time it doesn't apply is for our leased physician offices. So we have physician offices that are leased out to providers that are not part of North Kansas City Hospital. They're not owned by North Kansas City Hospital. In that case, the practice isn't owned by North Kansas City Hospital. In that case, our obligation has not been triggered. So if a patient passes out in the orthopedic office on the 6th floor of the pavilion, that does not trigger an EMTALA obligation. As soon as they get that patient out to the hallway in the pavilion and they say they really need medical treatment, our EMTALA obligations are triggered. Our EMTALA obligations are also triggered when a patient is in a ground or air ambulance on hospital property. So they can still be in the ambulance, they can still be in the helicopter. As long as they're on hospital property, our obligations are triggered. So the next element of, our obligations have now been triggered, so what are our obligations? Our first obligation is a medical screening exam. And the important thing to know about the medical screening exam is that it's not triage. This is something more than triage. A couple of things about the medical screening exam. First of all, it can only be performed by qualified medical personnel. At our hospital, we define qualified medical personnel as nurse practitioners and physicians in the emergency department. We do have, by policy, some specially trained RNs, primarily in our OB department. They're the labor and delivery nurses who are also considered qualified medical personnel. But I would imagine that the vast majority of people in this room are probably not qualified medical personnel for the medical screening exam purposes. Now, the purpose of a medical screening exam is to identify whether or not the patient has an emergency medical condition. And in order to make that determination, we actually have to do a fairly thorough assessment. And we have to do an assessment that is consistent with the patient's conditions and that is consistent regardless of the patient's payer source. So the example of that is somebody that comes in with chest pain, right? We're going to pretty much treat every patient that comes with chest pain in the same way. They're going to get the same kind of evaluation and workup, right? The medical screening exam needs to be thorough enough to determine whether this EMC is present. And an emergency medical condition is really anything that places the health of the individual in serious jeopardy, that presents a serious likelihood of serious impairment to any bodily function or serious dysfunction of any bodily organ or part, and active labor. All of those things are considered an emergency medical condition. So if it's going to hurt the patient by not having them be treated, it's probably an emergency medical condition. And your medical screening exam has to be enough to identify that. Once we've identified that there is an emergency medical condition, we have to render stabilizing treatment to the best of our abilities. Obviously, if we were a smaller hospital, we might not have the capabilities that we have here. And EMTALA understands that. EMTALA understands that there are hospitals that have different levels of capabilities. But we have to do what we can for that patient to stabilize their condition such that it is not going to result in that deterioration of their body, loss of life, permanent impairment of bodily function. You may have a condition that caused the patient to seek care in the emergency room that is resolved, but you may still have an underlying condition that exists. An example might be a patient that presents in a cancer pain crisis. They might really just need for their pain to be better managed, but that doesn't mean that EMTALA obligates us then to make sure that they have an appropriate cancer care plan. The patient should be stable prior to discharge, and if they are unstable, then we need to either admit them to the hospital or we need to arrange for an appropriate transfer. And the appropriate transfer is another one of these obligations that has lots of rules under EMTALA. First, an appropriate transfer can only be made when a patient requests the transfer and understands the risks of that transfer, or if a physician certifies that the benefits of the transfer outweigh the risks to the patient. And we have two forms that we're going to go over in just a moment. So in order to provide an appropriate transfer, we have to first perform our stabilizing treatment. We've already talked about that. We have to obtain and document acceptance by the recipient hospital and make arrangements and verify that they have the space and personnel necessary to accept that patient. This is the point where the physician-to-physician communication is very helpful. We also have to send medical records, available test results, consents, and transfer forms. We have to arrange for appropriate transportation, and that is appropriate for this individual patient given their individual condition. Appropriate transfer, a lot of times it's going to be an ambulance, but in some cases it might even be the person's automobile. The real trick is that it is the physician that helps to make that determination of what mode of transportation is the least likely to result in harm to the patient during the transfer process. We also have to document the name and address of any physician that is not responding to our calls, and we need to have a uniform process for all transfers. And the way that we have that uniform process, again, is by these forms that we're going to go over in a moment. Now let's talk about insurance for just a moment. This is something that always comes up in EMTALA. I've already said that our EMTALA obligations are that we need to render care to patients, emergency medical care to patients, regardless of their ability to pay. Now, there are some patients, as we know, who do have insurance, but maybe their insurance has North Kansas City Hospital out of network. In those cases, it is okay to have a discussion with the patient about their insurance coverage, but it's very important that we are careful with the timing of that conversation. That conversation needs to not happen until the medical screening exam is performed, an emergency medical condition is ruled out, or that emergency medical condition has already had stabilizing treatment started. So really this conversation is going to happen either when the patient is essentially has an inpatient admission order written, or when that patient Yeah, it's really when they have the admission order written. And let's see. Generally speaking, a patient must be told that we will treat them here if they wish, regardless of what their insurance is, but that their insurance may not cover the costs. We have to present the information to them factually, and we can't try to persuade them. It is up to the patient or their decision maker to request a transfer after being presented with this accurate information. So this is not a situation where we have a physician certifying that the risk of the transfer is the benefits of the transfer is greater than the likely risk to the patient. This is a situation where a patient really has to request this for their own reasons, and we're still saying we can treat you here, it's up to you. So the transfer forms that I keep talking about. We have 2 transfer forms that we use to show that we've met all of our EMTALA obligations for a safe transfer. The transfer form may help prove that we've met our obligations. They must be filled out completely and accurately, and it is your job to make sure these forms are completed. When a patient requests a transfer for insurance reasons, we're going to talk about section 1. That's what we're going to use for them. So let's talk about the patient's request, refusal, and consent for transfer. As you can see, this form is divided into 3 sections. Every patient that you encounter is only going to have one of these sections filled out because only one of them is going to be appropriate to their clinical scenario. So the first section is the transfer request. This is when the patient says, I don't want to be treated at North Kansas City Hospital. They could be saying that for whatever reason they want. It could be that they're saying it because we've advised them that they are out of network, okay? The second section is called transfer refusal. This is the section that we use when a physician makes the determination that this patient can get better care elsewhere for their given condition, but the patient doesn't want to leave. They want to be treated here regardless of the level of care we can provide. So this might be an example where there was a burn unit, and we said, boy, you could really benefit from being transferred to a burn unit, and the patient says, no, I don't want to go to that hospital, I really want to stay here. That would be the transfer refusal. And then we have the transfer consent. This one is used when the physician determines that it is in the patient's best interest to receive care elsewhere. And again, the only reason that this happens is because we do not have either the capacity or some resource to treat this patient's individual condition. And this is the patient saying, my physician has advised that I should be transferred and it's going to be in my best interest, and I agree with them. So that's what section 3 is. This is also the section that you will use in those, albeit slightly more complicated situations where we have somebody who's being transferred to signature, especially if they're going to be transferred as an involuntary over there. So does that make sense? Okay, so the physician assessment and certification. This one has a lot of different parts to fill out. The first part is the patient condition. There are 3 options that you can check here. The first is the patient has been stabilized such that within reasonable medical probability, no material deterioration of the patient's condition or the condition of the unborn child is likely to result from transfer. The patient's condition has not stabilized or the patient is in labor. Those are your 3 options for classifying this patient. Next is our documentation that we've met all of our transfer requirements. So the first transfer requirement is the listing of the receiving facility. We have to list that receiving facility, and we have to list who we talked to at that receiving facility, including the date and time that we did so. The next section is the receiving facility physician. Who is going to be accepting that physician from the physician standpoint? Again, dated and timed. Next is whether we have included the appropriate medical records, including relevant laboratory results. And finally, that the patient will be transferred by some mode of transportation that is appropriate to them. So we're either going to say air ambulance, private vehicle, ambulatory with security, etc. Then we have our provider certification. Now this provider is actually that qualified medical personnel that it's typically the person that did the medical screening examination, but it doesn't necessarily have to be, but it needs to be somebody in that category of providers. They are going to include the patient's diagnosis, the benefits of transfer and the reason for transfer, and they are going to sign, date, and time that document. Now, we in the compliance department look at these documents every year and we audit them every year. And the things that we are looking for is to see that they are completed entirely and that every entry is signed, dated, and timed. The dates and times for these particular documents are incredibly important because they are what tells our story if we ever have the Office of the Inspector General walk in and say, we believe that you committed an EMTALA violation. We need to be able to show them minute by minute what happened with this patient and what happened with their transfer. Any questions about the forms?
So if you are the nurse for this patient and the doctor has signed their name and just put the date, they need to put the time in, and you can tell them they have to put the time. You can put the time for them, but the time has to be there.
Do we still have to have them sign a partial refusal of care if they don't want to be transferred? Like, does this cover, not the AMA forms, the partial refusal of care?
No.
Do we have to have them sign that?
Did you say a partial refusal of care?
Yeah.
I'm not sure that I know about a partial refusal of care form.
It's on the AMA form.
It's on the
They're
AMA
wanting to
form.
leave- They either want to leave the hospital and not get care, or they're just refusing specific treatment.
I would not use the AMA form if they don't want to be transferred. And there are a lot of reasons legally that I really wouldn't do that. So let's just keep this simple. If they don't want to be transferred, but they still want to get care, so they're going to get care here, then it would be that patient refusal.
So that bottom line needs to be a nurse practitioner or physician.
Yep, for the physician assessment, provider certification.
Someone brought up the fact last night that there is a physician that tells us we are qualified medical personnel, we are not. And we'll do some education with that physician.
And this doesn't even come into play if they refuse to transfer, this part of it.
Correct.
Okay.
So I would say anytime a patient actually gets transferred, there's going to be two forms. Yeah. Okay, brief recap on our transfer obligations. Our EMTALA obligations are the same regardless of the payer. We must provide a medical screening exam, stabilizing treatment, and arrange for an appropriate transfer. We can present information on the patient's insurance coverage after stabilizing treatment is performed and there is an order to admit. It is not appropriate to transfer a patient for insurance reasons without a request from the patient or from the patient's decision maker. If the patient wants to be treated here and we have the capacity to treat, even though North Kansas City Hospital is out of their network, they can stay. Is everybody clear on that? Now, the recipient hospitals also have obligations. Recipient hospitals must accept transfers if they have the capacity to do so. Transfers from other EDs are typically coordinated through our emergency department, and if you feel like we are acting as a recipient hospital, and the hospital that was sending the patient did not meet all of those transfer obligations that we just went over, then please report that to Stacy Carnes, and she will work with Jennifer Cozen to determine whether this is something that needs to be reported. So some common questions that we hear are, what if the patient wants to leave AMA? EMTALA doesn't mean that a patient can't leave AMA. So we're going to go through our regular AMA process. There's going to be the statement of the patient refusing treatment against advice and a responsibility release form that they'll sign. If they don't want to sign it, then we always say patient refused to sign, and that's totally fine. Same thing with a patient who leaves without being seen. I know that we have a form, the patient requests to decline medical screening examination. That's great if they'll fill out the form. If they don't fill out the form, it helps if we can at least get some basic demographic information for them, especially if they skipped the mini-reg for some reason. That mini-reg is actually very important because it serves as our EMTALA log, which is another requirement of the statute. What if a patient complains about the wait? Same thing. There's nothing about EMTALA that says that we shouldn't have a wait. There's nothing about EMTALA that says that we shouldn't use the triage purposes that we're using, as long as we're not doing something silly like triaging people with the insurance that we prefer first. Of course, we would never do that. What if the patient expresses concern about payment? Our message should always be to that patient that we want to focus on getting you the care that you need while you're here in the emergency department. We can worry about payment later. So some other obligations that we have under EMTALA, including reporting inappropriate transfers. We have some signage requirements, which you should see in the emergency department. We have lots of signs that say you will be treated without regard to your ability to pay. We have to have that central log that I just mentioned. We have to have an on-call list of providers. And we have other on-call obligations that basically go into our contracts with our physicians who we are having as our on-call physicians. Each violation of EMTALA is subject currently to a $50,000 fine by the Department of Health and Human Services Office of Inspector General. The facts of an EMTALA violation may also lead to civil liability. So you may get hit with a $50,000 fine from the OIG, and that may be the least of your trouble. If you have a case where you failed to meet your EMTALA obligations and that failure led to a permanent harm to the patient. So here are some enforcement cases. Yay. This is the interesting part, at least. TriStar Summit Medical Center, this one is 2 years old now, but I thought it's a very good example. Hospital transferred an unstable patient for insurance reasons. The patient came to the emergency department after consuming a bottle of antifreeze. ED personnel determined that the patient should be admitted to an ICU, and despite the availability of beds, transferred the patient because they did not accept his insurance. The hospital failed to provide stabilizing treatment prior to transfer and transferred without the patient's consent or a physician certification that the benefits of the transfer outweighed the risk. So the hospital was fined $40,000, and again, they are absolutely subject to a separate lawsuit by that patient. Next, we have Covenant Medical Center in Waterloo, Iowa. This one is a very interesting case to me, $100,000 settlement. Now, what does that tell you? Didn't I say that the maximum fine is $50,000? Yeah, it's bad, right? What that really says is that there was more than one instance that the OIG was investigating, and in fact, in this case, there were 3 instances. The allegation, according to the OIG, is that the hospital failed to provide an appropriate psychiatric screening examination or stabilizing treatment for 3 patients. And I think that the 3 patients' stories are very interesting. The first is a woman presented to the emergency department complaining of depression and suicidal thoughts, but was later discharged with instructions to follow up with her primary care physician. Now, I didn't mention this before. This hospital had on-call psychiatrists, but they did not call or do any kind of psychiatric assessment for any of these patients I'm about to talk about. The second one, a child presented to the emergency department following violent outbursts, but was later discharged with instructions to follow up with his primary care physician. And this is the one that I think really pushed the OIG over the edge. A man presented to the emergency department stating his mind was disturbed, but later eloped from the emergency department into single-degree weather, wearing paper scrubs while his discharge was processed. So this was another patient who they basically said, you need to follow up with your primary care physician. We are discharging you now. But his body was found about 300 feet from the door with the cause of death attributed to hypothermia.
Didn't you say he eloped though?
He eloped during the discharge process, yes, but he's a psychiatric patient. So we typically don't want our psychiatric patients to elope.
Well, we never want them to, but if they do, it's beyond our control on some level.
Well,
If
and
they don't have they're voluntary. If they're voluntary, yeah.
yeah, he was being discharged. So this is a complicated situation because the allegation is that his psychiatric condition was probably such that he should have been involuntary, but they didn't do enough of a medical screening exam to determine that. So they've set up discharge, go follow up with your primary care. While he was being discharged, he's like, to heck with this, walks outside in his paper scrubs and dies. Bad.
Any psychiatric.
Correct, and that is the allegation. Correct. Then we have Cape Fear Medical Center. This is in Fayetteville, North Carolina. $40,000 settlement because they failed to provide an adequate medical screening examination and stabilizing treatment for a woman who presented to the emergency department in labor with her 3rd child. The allegation is that they did not do really much of a medical screening exam at all, and in fact, she was very much in labor, and by the time she got home, she drove herself home, by the way. She delivered her baby immediately at home after driving herself home. So that was a $40,000 fine. Remember I said that active labor is automatically considered an emergency medical condition? And that was specifically added by Congress because of those stories that were happening in the 80s with women delivering on the sidewalk or in a taxi cab right outside of a hospital. Then we have Phoebe Putney Memorial Hospital in Albany, Georgia, another $40,000 settlement. The allegation here is that a 73-year-old man was transported to another hospital by EMS and presented with hematuria, bleeding at the site of his Foley catheter, and abdominal pain. The patient required a urological services that were unavailable at that hospital. The hospital requested Phoebe Putney to accept the transfer, and the OIG alleged that their on-call urologist refused the transfer even though they had the capability and capacity to treat the patient. So this is the OIG getting mad at a would-be recipient facility who wouldn't agree to see a patient even though they were able to. McLeod Medical Center in Dillon, South Carolina. Here we have another allegation that they failed to provide an appropriate medical screening exam and stabilizing treatment. The patient presented to MMC after being assaulted and hit in the head. The patient resisted efforts by his mother to get him into a wheelchair and to enter the emergency department. The security guards observed the patient's behavior and told the patient's mother that if she brought her son into the ED, the guard would have him locked up. The OIG alleges that the mother explained to the security guard that the son had been hit in the head and was bleeding, and that a guard allegedly answered by reasserting that he would call the police if her son entered the emergency department. At that point, the mother left with her son and later took him to another hospital for evaluation and treatment, and of course, he had a head bleed. So, our final one is Belton Regional Medical Center. This is in Belton, Missouri, $40,000 settlement with the OIG, alleging that they failed to provide an appropriate medical screening examination for 2 patients who came to the emergency department with emergency psychiatric conditions. The OIG is really focusing on our provision of medical screening examinations that are appropriate to identify that emergency medical condition in psychiatric patients. So psychiatric crisis is definitely seen as an emergency medical condition. Brief recap on all of our EMTALA obligations. All individuals who come to the emergency department shall receive a medical screening exam by a qualified medical personnel. They will be provided with stabilizing treatment, and when necessary, will be provided an appropriate transfer. We do have a policy called Emergency Medical Screening Treatment Transfer and On-Call Roster, in case you ever need to reference it. If you suspect an EMTALA violation, I ask that you report that immediately to Stacy, and Stacy will work with Jennifer Kozin, our Vice President and General Counsel, to investigate and determine our reporting obligations. Any questions?
I have a question. Sorry,
Yes.
guys. Okay, when somebody's coming in by ambulance, they're not here, but they're requesting to come to our facility, but we're closed to ambulances. Is that an EMTALA violation to not accept that patient?
No, EMTALA only kicks in when they're on our campus. Now, as soon as they get onto Clay Edwards Drive, I would make the argument that
Okay.
we can't get around EMTALA.
Well, that's what they do. They wait until they don't call until they close up. They go, try them on the property. So,
Oh, they know.
Well, sometimes the patient will request us even if we're closed.
Yes.
But they have a form they're supposed to have that patient sign in that ambulance before they bring them here.
Any other questions? Okay, well, thank you all very much for your time. I'll see you in 2 years-ish. Thank you very much.